are two cases of optic fit in which I'll show the mistakes I used to make earlier.
Methods of internal limiting memory.
This is a young girl, a case of optic pit with macular schisis, and you see this. She had counting finger vision. This was the time when I was not doing foveal sparing fields. It was a routine, simple hyaloid removal. So my technique has always been to flap the pit with ILM, a nasal flap, and in my initial cases, I used to do this non-sparing peel, and I would do an extensive peel along with a flap onto the optic pit from the nasal flaps onto the optic pit, and leave the patient with 20% SF6, explaining to them that the visual improvement would be slow and gradual. This is this patient, and she initially did well. The flap was in place, everything was good. And then 6 weeks post-op, she developed this break. And that was the turning point, because before this, I had not had a break despite non-fovea sparing peels. Then I changed my technique in the subsequent cases. Frankly, I do about 3 to 4 such cases a year, it's not more. So over the years, the series has built up, and now I'm doing this procedure. I've done about 4 to 5 cases with this technique, where this patient had an associated coloboma also. So what I do now is, besides doing my flap, just to safeguard the cystic macula, even if on settling down it tends to develop a hole, I flap it from before. So what I do is an envelope flap technique. First, I do my nasal flaps. Then I go ahead with this what I call as more of a fortifying the cystic fovea surgery. So I just put an envelope of flaps on top of the cystic fovea, do a temporal relaxation. So this is the technique which I follow now, and my experience has been fairly nice. And visual acuity here was 618.
Do you do any laser during surgery, temporal to the optic nerve head?
My second talk is on, we can discuss them both together.
Okay.
Is on myopic macular traction maculopathy. And I think it's an important thing where myopes are undergoing cataract surgery. It's important to see what lurks beneath. This is one of my favorite slides, where I compare juvenile schisis to myopic schisis and show that here the ILM is under traction, there it is not. So I like to basically simply classify it in my cases as simple, where there is one zone of schisis, or compound where there are multiple zones of schisis. So this is a 38-year-old female, diminution of vision in both eyes, 6/12 visual acuity in the left eye, early posterior subcapsular cataract, and myopic foveoschisis. In this OCT, we could identify the traction on ILM temporal to the fovea very well. the patient was explained about the possibility of surgery if the disease progresses. I did not want to operate at 612 vision at that stage, and she was a relatively young patient. Obviously, because I was not very encouraging at that stage, she also said she would also like to wait, and then she slipped to 636 vision, and she came with this picture. The traction had gone up. And we chose to do the surgery for her. Here also, I like to do foveal sparing surgery, a hyaloid removal. There is many times vitreoschisis present in these cases. And I again support my cystic fovea with a nice flap. And I pay particular attention to the cases, to the areas of traction. Like here on OCT, the temporal traction was very visible. It was also clinically visible on the table, and I went and did an extensive temporal peel, relaxing the temporal to the fovea retina. And this was our result. I use 10% C3F8 in these patients. I don't use a full 17%. And patient progressed well, pre-op, and that's 1 week post-op. 618, 3 weeks post-op. Another case, 2120 vision. These are myopic eyes. And this was again the period I was not doing foveal sparing field. And this was an only-eyed patient. But he did well with a phaco, vitrectomy, ILM peel, and gas for myopic foveoschisis. Pre-op was counting finger, post-op was 2120. Later on, he went up to 2040. So good fundus ignition this is important for anterior segment surgeons in myopic, and be wary if the cataract and visual loss do not correlate. OC is a must today. There is variability of response to surgery. Combined surgery works better. History of recent progressive decrease in vision is a good prognostic marker. For me, peripheral retinal checkup is very important at conclusion in these eyes, and in the absence of macular hole, ILM peeling alone can give good results. I have done it with macular holes also because I don't do macular buckle. For anterior segment surgeon, it is important to rule out MMT before. Another patient, only eyed with severe traction, and this was the result. Visual improvement was partial, but 5 patients as he was seeing better. Thank you very much.
Excellent videos, Dr. Chawla.